Good afternoon. Welcome everyone to this session. So this is the KN06. My name is Felipe Coimbra. I'm a surgeon from Brazil, São Paulo, and I'm very honored to be here this afternoon in this very important session, actually. So it's about quality of care from the patient's perspective. And as I said, I think this is probably one of the most important points we should discuss in this Congress, and also maybe one of the most misunderstood situations from the physician's side. So, what would be the question and the answer then to Melinda Bacchini, who is here, and will help us to understand a little bit more about this topic. So, what is quality of care? So, is it being alive, receiving like the best treatment, be able to participate in clinical trials, receiving good care and affection for the team, quality of life. So I think these are very important questions we should try to understand and move forward in the right direction as physicians. So then I invite Melinda Bacchini, who is going to talk about us. She has a very interesting story. And we know she's a patient survivor from the cholangiocarcinoma cancer. And thanks to Cholangiocarcinoma Foundation, Stacy, who is here for the suggestion of her name. And I know she's going to talk for us about some of her experience as patient, and also from the advocacy, and also patient education, and we work a lot on that. So thank you, Melinda, and please.
Thank you, everyone. Good afternoon, and it's a pleasure to be here and a privilege to be able to speak on behalf of the patients. So I'm Melinda Bacchini. I'm from Billings, Montana. I'm a wife, I'm a mother to 6, and I'm a 12-year survivor of stage 4 intrahepatic cholangiocarcinoma. December 1st, 2009 is a day I will never forget. It's the day I heard those words, you have cancer. I still remember where I was standing in my home and everything that happened in that moment. My kids had left for school, my husband left for work, and my gastroenterologist had called on the phone. And I remember her saying, "I'm so sorry, it wasn't on my radar, but you have cancer." And then I didn't hear a word she said after that. Everything went blank. I called my husband home, we had a good cry, and then he had to call her back and get the information we needed to know for our next steps. They told us it was most likely cholangiocarcinoma, and we had never heard of that. We were cholangio what? That it was a rare cancer, no proven treatment. Surgery was the only chance at potential cure, but even if you're fortunate enough to have surgery, the recurrence rate is quite high. So my first major decision to make was to find a surgeon. Who would I choose and where would I go? We received a second opinion from Mayo Clinic, but for personal reasons, I chose to stay home, and 3 weeks after my diagnosis, had 2/3 of my liver resected. They removed a 13 by 9 centimeter tumor, but unfortunately, 3 months later, the cancer came back in my lungs. The metastasis was confirmed with my first lung wedge, and it was at that time that I was labeled a stage 4 terminal cancer patient. I'd done enough research to know that if I was going to beat this disease at 41 years old and being a mother of 6, that we needed to find something new, so I wanted a clinical trial. I asked my oncologist to be aggressive and to look for one, and he found one at the time, but unfortunately my insurance would not cover the standard of care costs that went into participating in it. So I didn't do the clinical trial because I absolutely did not want to leave my family in financial burden or put them in financial stress, for something that we weren't sure was going to work. So again, I chose to have a second opinion with Mayo Clinic, but they couldn't offer me anything different at the time either, and so we went ahead and started with the standard of care gemcitabine and cisplatin. The weekly cocktail of Gem-Cis lasted for about 6 months until the toxicity built up, with ringing in my ears, some hearing loss, and a lot of neuropathy in my hands and feet. So they took the cisplatin away. I did gemcitabine for 6 months. The cancer spread from my lungs back to my liver, and then they tried Taxotere for another 6 months or so with no effects. So after about 18 months of doing chemo, I came to the decision of quality versus quantity. And I chose to stop all treatments, which was a hard decision to make. I didn't want my kids to think I was giving up. or that they weren't worth me suffering through side effects, to try to be here longer. But the quality of life I had was not good, and so we stopped treatments. But literally a few weeks later, I stumbled upon a clinical trial out at the National Institute of Health. And at that time, it was called the GI TIL trial. And I took it to my oncologist, and he said, I'll support you in whatever you want to do. But typically, they work with the University of Denver, because that's what's close to Billings. And I said, no, this is what I want to do. So my husband and I ended up doing all the legwork. We made the calls, we sent the records, we sent the blood, we did everything we had to do to get out there to be seen. We had our consultation and were accepted, and a couple weeks later, I was out there having my second lung wedge, where they harvested 4 tumors and removed the TIL. I was the 9th person to enter into the trial, the first with cholangiocarcinoma, and the first to have a response. I had an overall shrinkage of almost 30%, so almost a partial response, and I had no other treatment for 18 months and enjoyed a great quality of life. But in that 18-month time frame, the cancer started growing again, but the scientist who studied my T cells found that there was a T cell that was reactive to one of my mutations in my cancer, so they wanted to retreat me again with this treatment. So I went back again to start round 2, 18 months later, my third lung wedge for more tumors to be removed to harvest the TIL. And the second time around, I received 3 times as many T cells, like 126 billion, with 95% of that population being that mutation-reactive T cell. The scans showed tumors in my lungs, and then 6 months after my second T cell infusion, the shrinkage of the tumors that were in my lungs. The results of that treatment were published in the Science Journal. The New York Times did an article on my family, and within the week that this went out in the media, I received hundreds of phone calls from patients all over the world just wanting to have hope. They didn't need to know that this treatment would work specifically for them. They just needed to know that there was possibilities out there. And that, I think, was when my true love for patient advocacy was born. Unfortunately, 3 years after my second T-cell infusion, the cancer started growing again. So Dr. Rosenberg decided to be proactive. They did a thoracotomy this time and removed the remaining tumors in my right lung to resequence and do research. Back to the OR for my thoracotomy, 4th surgery on my lungs. And the research showed that the mutation-reactive T cells were still present. The same mutation was present in my tumors, but this time the tumors were infiltrated with macrophages that expressed high levels of PD-L1. So they chose to treat me with pembrolizumab. After 2 doses, I had my first scans, and there was incredible shrinkage just from 2 doses. I had a total of only 8 doses, and that was 5 years ago, March this month. So it's now been 5 years since I've had any treatment whatsoever. I'm very hesitant to say the word remission, but I'm hopeful. I actually have scans next month, so we'll see what happens, but I feel good, and I'm definitely hopeful. Because I had such a good response, and I know how fortunate I am, I felt really strongly about finding a way to pay it forward. So I started volunteering with the Cholangiocarcinoma Foundation about 10 years ago. 5 years ago, I came on as a full-time employee. I also serve as a patient advocate for the NCI Hepatobiliary Task Force, for the ECOG Akron GI Group, for the National Council of Research Advocates, and for the NCCN Hepatobiliaries Guideline Panel. And just FYI, we have a booth, the Cholangiocarcinoma Foundation has a booth in the exhibit hall, so stop by and get some information from us. So I wanted to briefly go over a survey that we did in 2019. The survey was born out of a conversation with myself, Stacy Lindsay, the CEO of the Cholangiocarcinoma Foundation, Dr. Mathel and Dr. Roca, and we were trying to better understand decisions made in caring for patients, specifically cholangiocarcinoma and pancreatic patients. You heard my perspective when it comes to social support and the strength and guidance I received from my family. You heard about my decisions to have surgery, a total of 5 to be exact, the non-surgical therapies I tried with chemotherapy, and the challenges that came with them, and finally my decision to try a clinical trial, which has ultimately prolonged my life. I think you will see that some of the decisions I made throughout my journey reflect some of the patients' wishes in this survey. Our aim of the survey was to better understand the beliefs, wishes, and perspectives of pancreatic and cholangiocarcinoma patients when it comes to their cancer care. In 2019, we distributed a 46 question survey through the PanCan and CCF networks. Over 1,000 surveys were completed, 2/3 being done by pancreatic patients and 1/3 by cholangiocarcinoma patients. And briefly going over the demographics of the patients, about 85% of the patients were in the age range of 45 to 75 years old. The majority were female, and the education level varied between the group, with half having at least a bachelor's or master's degree. And almost all had children. We can see when it comes to social support for patients, it comes in several different ways. Similar to me, the majority relied on family and friends for their main support network. And interestingly, of the patients who were married, only 50% or so said being married affected their decision-making when it came to treatment options. And slightly more than 50% said having children affected their decision-making when it came to treatment options. While support networks are an important part of the patient journey, over 50% of patients say it does not affect their treatment decisions. I relied on my spouse and children to help navigate my decisions, but when it came down to it, the final choice was mine to make. Now moving on to the patient perspective of surgery, and I have to say that I've thought a lot about these responses in this survey as I've been listening to the presentations the last couple days, especially the debates on clinical cases. Over 2/3 of our patients had at least one surgery, as I well understand having a total of 5 surgeries, and knowing I would definitely do it again if it were necessary for my treatment plan. It's important for you all to know that almost 30% of patients would be willing to undergo surgery even if the risks of complications were high, including death. I know I was willing to take a high risk for a chance at a possible cure when told that surgery was the only option for a potential cure. While half of the patients would undergo surgery if it improved survival chances for greater than 2 years, about 20% would also undergo surgery for survival of only 3 to 12 months. And as I shared with you earlier in my story, I came to a point in my journey where quality of life became more important than quantity of life. And my fellow patients agreed. While we would all like to increase our survival time, there comes a point when choosing quality of life is more important than quantity. An overwhelming over 80% of patients would seek a second opinion if told that they were not eligible for surgery. Surgery is so valuable for us that another over 40% of patients would seek a third opinion if told they were not eligible. And again, surgery is so valuable that 50% of patients would be willing to have surgery even if there was not a chance for a cure, which emphasizes the importance of surgery when it comes to treatment options. We still want the cancer to be taken out even if it won't cure us. As I shared earlier, my cancer returned 3 months after my liver resection, and I imagine it had probably already spread, we just couldn't see it at the time. And I'm glad we couldn't see it because I know I wouldn't have been able to have surgery, and I think the surgery bought me the time to find the clinical trial that got me here today. The majority of patients are willing to travel greater than 200 miles to have surgery at a specific institution. And again, they are willing to travel greater than 200 miles to seek surgery from a specific surgeon. When it comes to non-surgical therapies, as chemotherapy and targeted therapy, over 90% of patients viewed biomarker testing as an important and necessary part of their treatment plan. Patients are aware of biomarker testing through initiatives from advocacy organizations such as Know Your Tumor from PanCan and Biomarkers Matter from the Cholangiocarcinoma Foundation. And they're proactive about wanting their treatments to be personalized, so please get your patients tested. And as I was willing, so are other patients to undergo treatments with severe side effects, even if it would, severe side effects if it would extend their life. And while the majority of patients would only endure side effects for 3 to 12 months, about 25% are willing to endure them for over 2 years. A significant number of patients are willing to try a treatment even if there's no guarantee of it helping them, which most patients do when they're told there's no curative regimen. When it comes to financial debt, as I said earlier in my personal experience, I wasn't willing to put my family in financial debt, and about 40% of patients agreed with me. But I feel it's important to note that the other 60% disagreed with me and were willing to take on some form of financial debt, including bankruptcy. Similar to surgeons in specific institutions, most patients are willing to travel greater than 200 miles to receive treatment, as I've been doing for the last 10 years from Billings, Montana to Bethesda, Maryland. And again, as I was separated from my family for extended periods of time for both TIL treatments, other patients are willing to be separated from their families as well. Again, myself included, being hospitalized for my cell treatments, patients are willing to be hospitalized in order to receive their treatments. And similar to the theme of our willingness to take risks, when it comes to our doctors, most patients want their doctors to take risks with their treatment plan. Patients are willing to endure a fair amount of pain, an average of about 7 out of 10 on the pain scale. And when we choose not to undergo further treatment, we still want our symptoms managed and to be taken care of so we can have some sort of quality of life. If told that the chance of treatment working is so low it is not worth the risk, most patients felt that their doctor had their best interest at heart. Yet on the other hand, almost 40% felt that their doctor was giving up or was not a risk taker. And finally, moving on to clinical trials, which is a huge part of our treatment plan. An overwhelming 95% of patients who took this survey are open to trying experimental therapies. And over 80% are willing to participate in clinical trials. We just need the opportunity and the access to do so. And as I was willing to enter into a trial where there was no proven success, so were 60% of my fellow patients. As patients, we all feel the hope that we could be the first person to have a response, as in my case I was. When I was left with no further options for treatment, I entered into the clinical trial with the feeling that I had absolutely nothing to lose and everything to gain. 85% of patients would enter into a trial that has high risk for a chance at better outcomes. Again, the hope for a potential better outcome is worth the risk when you have been told there's no proven cure. 60% of patients would enter into a phase 1 clinical trial, and over 90% would be willing to participate in a phase 2 trial of a new drug being tested either alone or in combination with standard of care. And equally important, 70% would enter into a randomized phase 3 trial of standard of care versus experimental drug. But when it comes to placebos in the clinical trial setting, most patients would only enter into a trial with a placebo if there was an option to cross over after 6 weeks. Otherwise, they would not choose a placebo trial at all. So in summary, when it comes to social support, I want to emphasize that patients' decision-making is somewhat influenced by their social support system, but ultimately, patients are making their own decisions. And when making decisions on surgical and non-surgical treatments, we are willing to take significant risks in order to receive a chance at a better outcome. And in the clinical trial setting, patients are hesitant to receive a placebo unless crossover is an option, but we are most definitely willing to enroll in clinical trials. I quickly wanted to highlight 2 new survey results with cholangiocarcinoma patients that I was honored to be a part of. The results of these surveys were both presented as posters at GI ASCO this year, among other conferences. The first survey was shared with cholangiocarcinoma patients at the 2021 Cholangiocarcinoma Foundation Annual Conference. The goal was to evaluate clinical trial enrollment, barriers that limit clinical trial enrollment, and biomarker testing. 204 surveys were completed by 120 patients and 84 caregivers. 57% of the population were treated with chemotherapy and 25% with the targeted therapy. 77% had biomarker testing done, in which almost 80% of the testing was requested by treating oncologists, with about 20% of the requests coming from patients to their oncologists to order the test. 27% of patients enrolled in clinical trials, with 25% enrolling in at least 2 clinical trials. The top reasons for not enrolling in trials were due to not having an actionable mutation, presence of a non-measurable tumor, biopsy not sufficient for testing, along with age, brain mets, and infections. In summary of this poster, we know that enrollment rate is still low for cholangiocarcinoma patients. We need to better evaluate eligibility criteria, which is a critical barrier to enrollment of clinical trials. We need access to more clinical trials, expanded access programs, and better design of trials for more opportunity and hope for patients. The second survey was a collaboration between Emory, CCF, and Citizen to evaluate health-related quality of life associated with enrollment in clinical trials and receipt of targeted therapy among patients with cholangiocarcinoma. 208 patients that are engaged with the CCF completed two validated health-related quality of life surveys: the Functional Assessment of Cancer Therapy, the FACT, and the Hepatobiliary and Comprehensive Score for Financial Toxicity, COST. 75% had intrahepatic cholangiocarcinoma, 57% underwent resection, of which 48% had disease recurrence, 22% enrolled in a clinical trial, 80% underwent biomarker testing, of which 29% received a targeted therapy. This data suggests that enrollment in a clinical trial or receipt of a targeted therapy does not affect a patient's physical, emotional, social, or functional well-being. However, patients report a higher financial burden. For patients with cholangiocarcinoma, clinical trials and personalized therapy are mainly offered late in the advanced setting, at which point a significant financial toll has already been endured. Further, they are often only available at large academic centers, creating a physical barrier to access. These findings underscore the need to increase availability and eliminate physical and financial barriers that threaten access and utilization of personalized and progressive therapies. I want to thank you for the time I was given today. Thank you to all the patients who took these surveys and for all who made this presentation possible. I'm so thankful for the grace of God, the doctors, the surgeons, the researchers, and the scientists who are willing to take the risks to get me here. 12 years ago, when I was diagnosed, I begged God for 5 years to get my children a little bit older, and I'm happy to say that 3 years ago, I became a grandma for the first time. I hit 2 more big milestones last year with 2 daughters being married. Talk about financial toxicity. Anyway, 12 years ago, I couldn't even imagine these events happening. And more good news, hopefully today I'll hear from one of my daughters that she will be expecting my 2nd grandchild. And as grateful as I am for being here to experience all the important and happy milestones, I'm even more grateful that I was here for the most tragic event in my life. 2 years ago, I lost my 24-year-old son, Skylar, unexpectedly. I'm grateful I was here to get my family through this tragedy and to be here to help raise my first grandson, Skylar's son, Sawyer. The bright spot in this story is that Skylar was an organ donor, and we were able to donate his organs, and he saved at least 5 other lives. We gave his liver to another cholangiocarcinoma patient, which made it even sweeter, as I know how proud Skylar would have been to help another person fighting the cancer his mom had. Thank you for your time.
Thank you, Felipe. Melinda, from the Scientific Committee of the IHPBA, the Scientific Committee of the IHPBA, we appreciate a lot your greatness to accept this task to give a keynote in our meeting, a keynote that we will remember forever. Thank you very much.
Thank you.
I'd like to thank you, Melinda, for this great talk. Really, it was amazing to see your experience, your examples, and how you came over all these situations. And I'd like to open for any comments or questions, if we still have a few minutes, if anyone from the audience wants to comment or make any question to Melinda.
I don't think I have any.
I'd like to just make one. So how do you think do physicians, what are the physicians' perceptions on your results? I don't know if you have this feedback, if there is maybe this would be another study, another question to do. Making a hypothesis that we may understand partial of it, what would be the second step?
Just wondering if maybe Melinda could share some of her observations from the meeting. We've been in a lot of interesting conversations about quality of life for patients, but maybe share some of the things that you observed.
Yeah, as I was listening to the debate on cholangiocarcinoma the other day about, them choosing who gets surgery and doesn't, it just reminded me of these results and the risks that patients are willing to take, and especially the ones who are told, they're not eligible for surgery and they're willing to go get another second opinion because they're wanting someone to say yes. And I think that maybe the way that the communication between the physician and the patient should be looked at and how it's explained so the patients better understand maybe why we can't have surgery or what the rationale is behind it. I think I saw several slides on the patients with resection and different, positive nodes, might not have had any better outcome for patients who didn't have resection. And there's things like that might make better sense to patients when they're told they're, not eligible for surgery maybe. I just think it's all in the way that the options are presented to the patients. And then, of course, transplant now has a new meaning to me and a new place in my heart. And I'm excited to see that they're doing more transplants for cholangiocarcinoma patients, especially intrahepatic. I think that's exciting. And the opportunity for living donors to be a part of it too is especially exciting, and to see the results of that coming up. So I was really excited, and like I said, it has a special place in my heart now, so I want to see that moving forward.
I always forget to bring Kleenex to your talks because I'm always then, I have to get it on my sleeves. The question about the work, the poster from Arizona that you guys presented. So when you identify these barriers to clinical trials, how does that then, as Felipe mentioned, get communicated to the clinical trialists or the research associates to see how we can improve that process? Or is that work ongoing?
Well, that definitely is ongoing. And I think the biggest barrier we have is access to clinical trials. And when you're newly diagnosed, most patients don't know about clinical trials. So we need the providers to be able to let them know what the options are, even if there's not an option in that where there's, first seen or the institution they're being seen at. The good news is 12 years ago when I was diagnosed, there was only a handful of trials to choose from. And now, if you were to look on clinicaltrials.gov, there's 106 in the US alone, 300 and some worldwide, that a cholangiocarcinoma patient would be able to participate in. And that's not counting the solid tumor trials. So there's so much opportunity, but access, they're limited to where these trials are being run, the financial burden of getting there, of traveling to the trials, of the costs that it takes to participate in it by having to stay in a town they don't live in, the childcare, that you have to arrange, the work missed, all of that is a barrier. And then the eligibility criteria. We've been working with the FDA to try to revamp the eligibility criteria for cholangiocarcinoma patients, and I think that will be helpful too. As I was listening to a talk this morning about whether a patient was transplantable or not, they were like, well, what's the age? And I hate that. I don't think we should go by a number. Treat the patient, not the number, because there's a lot of different older people who would probably fare very well, but why should they be disqualified just because that's a criteria?
Can I make one last question to everyone here? We as physicians talk about, I was thinking about now, like pre-rehabilitation for surgery, for example. I don't know if it already exists, maybe. Do you think we could think on doing a preparation, a guidance for patients once they discover they have cancer? So you should think on this, where is your clinical trial, where to look at. You may have this already, I'm not so sure. In this way, put in this way. So you should think on your financial side and how to prepare it to the future and how to prepare your family. I think this would be nice.
Oh, yeah.
To build it. So maybe we could do it together with the HPBA, and you.
Absolutely, we're open to.
I think this would be very helpful for patients. Yes.
Anything to help the patients.
Yes. Okay. Okay, so we're on time. Thank you very much.
Thank you. Thank you so much.
Okay, welcome, ladies and gentlemen, to this exciting session about a hot topic in treatment of chronic pancreatitis. And this refers to the topic of the value of total pancreatectomy and islet autotransplantation for chronic and recurrent pancreatitis. And we are very glad to have Dr. Varya Krishner from Stanford here to present her experience on this procedure. Thank you very much.
Let's see. Let's see, the slides are not moving forward. They're not advancing. One second. So I would like, can I go back for a little bit? Let's see. All right, so I would like to thank the Congress for giving me opportunity to present. I'm currently at Stanford. However, I've spent many, many years at University of Minnesota, thus my experience in total pancreatectomy and islet transplantation. So I have no disclosures. As we all know, chronic pancreatitis as well as acute pancreatitis associated with multiple symptoms. But when our patients come to us, primarily it's the pain and it's the terrible quality of life. The pain comes from increased intraductal pressure as well as inflammatory damage to the sensory neurons around the pancreas. Also, over time, if the disease progresses, it can lead to the gland burnout and loss of the islet function, as well as loss of the exocrine function, contributing to the GI complications. And in the worst case scenario, it does lead to systemic complications with multi-organ failure, and it can cause the mortality. So the main management, as we're aware, is the medical management, endoscopic management, first targeting this symptoms. However, if that does not help and these options are exhausted, we talk about drainage and drainage plus resection procedures. Unfortunately, those procedures have been shown fail up to 50% of cases, and they do not always they're not always appropriate or suitable for patients with a diffuse small duct chronic pancreatitis or acute recurrent pancreatitis that we see quite a bit now. Also, if the disease progresses, it can also impair the islet function. So if we will choose the total completion pancreatectomy and islet transplantation, the outcome is going to be suboptimal. So the total pancreatectomy and islet autotransplant addresses two issues. Number one, pain relief for the patients, but also minimizes the risk of diabetes, long-term diabetes for those patients. We'll talk about the history and indications, surgical procedures, as well as islet isolation and postoperative management and outcomes in this patient population. So the first procedure was described in 1970s by Dr. Sutherland and Dr. Najarian, and the first patient was transplanted in 1977. However, at that time, they really looked at this as an intermediate step to understand the allo-islet transplantation, but remove the immune component out of this. However, the auto-islets really found its home among the patients who have a pancreatitis. So this is the map of centers that are currently performing the procedure in the United States alone, and currently over 1,500 cases were performed across the globe. The indications, and these are the classic indications which evolve over time a little bit. So it's either chronic pancreatitis that was diagnosed based on imaging or histopathology, as you can see here, history of recurrent acute pancreatitis, where at this point, 3 or more episodes with the lipase elevation 3 times of normal, or hereditary pancreatitis with compatible history and proven genetic mutation. Also, those patients usually either on chronic narcotics or actually have the impaired quality of life due to their pain, because a lot of them cannot work, they cannot go to school, and have multiple readmissions. Complete evaluation with no reversible causes, as well as failure to respond to medical and endoscopic therapy. And lastly, adequate islet cell function, and that's specifically for islet transplantation, either non-diabetic or C-peptide positive. And this is a big procedure, and also it's a long recovery. So, and patients should be willing to work with us on recovery as well. So lack of medical or psychological contraindications to the procedure. So other indications been described in the literature, one of them following the trauma, following partial pancreatectomy due to the ductal disruption in pediatric population where part of the pancreas was isolated and islets were given back to the child, and that was using the interventional radiology techniques. More controversial is actually islet infusion from the non-disease affected pancreas portion from patients who had pancreatic resections for tumors. This is something that's not performed in the United States currently. However, there have been cases in the past at my former institution that it was actually done. There is also evolution of indications. This is the publication, as you can see, from 2012 by Dr. Sutherland, where mostly the indication was idiopathic pancreatitis. I think our diagnostic ability is better now, so it's actually indications are reversed, and over 50% of patients that we see now have genetic underlying causes of pancreatitis. At the same time, there's an evolution of the patients. So the first adult was transplanted in 1977. In 1989, first teenager case was reported. And over the past, actually 20 years, the procedure became more acceptable for pediatric population. So this is the case series from 17 children who mostly had genetic risk factors for the pancreatitis. And with a follow-up over 2 years, all of them discontinued narcotics. The hospitalization rate significantly decreased from 5 per patient per year to 0.35 following the surgery, as well as a lot of them became insulin independent. So this is a lot more acceptable. It is a big procedure. It's a complex problem. Therefore, a multidisciplinary approach is important. And we have involvement of gastroenterology, endocrinology, surgeons, as well as the nurse coordinator who oversees everything. And we work tightly with health psychology, pain management, as well as the islet isolation team, as you can see here. So the procedure itself includes removal of the pancreas. Mostly we remove the duodenum, but we preserve the pylorus, as well as the spleen and the gallbladder if gallbladder is still present. Following the pancreas going into the lab, the islets are being isolated. During that time, we perform the Roux-en-Y reconstruction, as you can see here, and islets are infused into the portal vein once they come back from the laboratory. Can I take a little sip? I apologize. Thank you. So during the infusion, we also measure the portal pressures and portal flows because there is a risk of blood clotting as well as bleeding with portal pressures going above the 25. So at the end of the procedure, we place surgical drain, primarily monitoring actually for chyle leak in addition to the bioleaks, as well as placement of gastrojejunostomy tube for providing the nutrition as well as decompression of the stomach, because a lot of those patients have the GI dysmotility. So the evolution of surgical procedures, and here I will actually just cite 2 cases. I apologize. Is it okay if I'll sit down? I'm very sorry. So the evolution of surgical approach. Thank you. So the evolution of surgical approaches, I'll talk about 2 cases. So first is a laparoscopic approach that was actually described by Dr. Fenn and his colleagues. Out of 32 patients that were evaluated, 22 were offered laparoscopic approach with 10% conversion rate. At the same time, the robotic TPIT was also introduced by the Arizona group, and when you compare the complications and outcomes, they're pretty similar. However, this is a limited experience with a carefully selected subpopulation of the patients, so it's very hard to compare them at this point to the open approach, as there is a great variability among the patients, including some patients with a minimal change in disease versus those who actually have a significant pancreatitis changes and severe inflammation during the surgery. So the surgical considerations that I would want to draw attention to, number one, this is the patient with severe pancreatitis that I operated on a few years ago. He had multi-system organ failure as well as necrotizing pancreatitis the 6 months prior to surgery. This was his CT, so you can imagine that in this situation, sometimes it's very hard to perform the dissection, and it's more treacherous, and vasculature can be significantly involved with significant complications. Other unexpected things that you can actually see during the procedure involved this patient who presented with pancreatitis and a very curious CT findings. However, none of the preoperative testing identified any diagnosis other than pancreatitis. So the patient was counseled that the pancreatectomy will be performed. However, if the pathology is going to be concerning, we will not isolate the islets. As you can see, the neuroendocrine tumor was diagnosed at that time. This is more unfortunate case, and this is probably the only case in the literature where patient underwent total pancreatectomy. This was an older gentleman with a chronic pancreatitis for many years. And a year later, he presented with metastasis to his liver from following the islet infusion. So at this point, many centers do test patients preoperatively for tumor markers if they have risk factors that are concerning for potential future pancreatic cancer. So in terms of the islet isolation, that's a secret sauce for this procedure because you require, at least in the United States, GMP, good manufacturing practicing facility, and highly qualified team that consists of between 4 to 5 members. So, and that team should be able to isolate islets from this beautiful pancreas and also from this not so beautiful pancreas that underwent chronic inflammation and fibrosis. So in terms of how the process happens, once pancreatitis is removed, the additional tissue trimming occurs and following the cannulation of the gland and actually distension of the gland with enzymes. Next, the enzymatic as well as the mechanical digestion starts with the Ricordi chamber. Even following that, there is still quite a bit of exocrine tissue that can remain in some of the glands, especially those that are very fibrotic. So the Kobe cell processor actually used for purification via the gradient of those islets. Next, the quality assessment is performed and islets are delivered back into the lab. So the average time at this point is about 4 to 6 hours for the islet isolation. So the success of out-islet transplantation depends on quantity as well as quality and function. When I talk about the quantity, it's been shown over a decade ago that more islets or islet equivalents that you give to the patient improves actually insulin independence long-term. As you can see in this example, up to 3 years. This was a study up to 3 years where if the patient receives over 5,000 islet equivalents per kilogram, there's over 70% chance of them being insulin independent. In terms of what happens to islets and when do you lose them? So the biggest loss that happens happens during isolation due to the enzymatic as well as the mechanical stressors and also inflammatory molecules within the culture. However, after the islets are infused into the bloodstream, one of the things happens is the instant blood-mediated inflammatory reaction. And that's actually activation of the innate immune system. And one of the things that we do in order to prevent or decrease this process is giving the heparin to the patients intraoperatively and then postoperatively. Other things that have been shown some benefit is alpha-1 antitrypsin, as well as the blockade of the TNF-beta to decrease this process. And the last thing I would like to mention that after the auto transplant, some patients do develop autoantibodies and actually lose their islets in that way, but this is it's mostly case reports. So in terms of islets quality, although most centers assess islets based on their viability and their morphology, it has been shown that if the islets are metabolically robust, such as increased oxygen consumption, as you can see in the first graph here, there is a high chance of insulin independence. Also, the islet size is actually inversely proportional to the insulin independence. So the smaller islets do better and function better within following the transplantation. This most likely has to do with revascularization and ischemia. So it takes about 3 months for islets to revascularize following the infusion, and as you can see here on the graph, 1 month versus 3 month density of vascularization of the islet transplants. So lastly, islet function. As we talked before, in our practice, at least in my past practice, where we had islet isolation facility on premises of the university, the islets were isolated while patient was still on the table, and they were infused directly into the portal vein intraoperatively. In some of the centers where islets are isolated in distant facilities and it takes longer period of time, islets are infused transhepatically into the portal vein. However, there are other options. So if there are high pressures within the portal system during the infusion, we stop the infusion and then look for alternative sites. A mental pouch or intraperitoneal infusion are usually our options. And there is some benefit to it because islet does not consist of only beta cells, it also contains alpha cells. And from this particular graph, you can see that yellow represents healthy controls, red, patients who received only intraportal infusion, and green, patients that received two-site infusion. And actually, the glucagon response to the hypoglycemia is better among the patients who received two-site infusion. So there is definitely might be a benefit to that. So in terms of area of remote isolation, and it becomes more and more important as more centers are performing those procedures and not everybody wants to pay for a very expensive islet lab. So what happens if you have a prolonged ischemia time on the pancreas and it takes time to bring islets back to the patient? So these two studies were performed by Tim Gartner. First study looked at 25 patients from 2 US centers that actually ship out their islets. And the mean ischemia time at the time was 10 hours. What they showed that there was no relationship between isolated islet equivalents per kilogram and solid organ ischemia time or the isolation time. So, and also there was no relationship between the percent change in C-peptide at 1 year post-total pancreatectomy and total cold ischemia time. Total cold ischemia time, they counted as pancreas out of the body, isolation time, and islets being transported back to the patient. However, when they compared the same group of patients to the patients who received their islets from local isolation, what's been shown that although the insulin requirements were similar between those two groups at 1 year, there is a better metabolic control among patients who received the locally isolated islets, as evident in change in C-peptide as well as the hemoglobin A1C. So in terms of postoperative care, it's a little bit different for adults and kids. For adults, it's about 2-day ICU stay, at least in it's been in my practice, and then they transfer to the floor. The main reason we actually keep patients in ICU because we use multimodality pain control, and Precedex is one of them. So the Precedex drip can be titrated only in ICU setting. That's the primary reason for them to be in that setting. Following that, the critical issues that those patients face is pain control. We use multiple modalities. We don't use only one modality that attacks only morphine receptors, so we use multiple different medication classes. Also, the tight glucose control is important. All patients are on insulin drip, and most of them get discharged on insulin because you do not want to stress those islets following the transplantation. Nutrition is very important. A lot of patients, as I mentioned before, have a gastroparesis. The intestines don't work as well because of the chronic narcotics. So they stay on tube feeds, jejunal tube feeds for several weeks following the transplantation. They continue on their anticoagulation as long as they're in the hospital, and of course physical therapy because it's a significant procedure. So these are the common problems or issues that we see among those patients during the first hospitalization. So islet contamination is quite common. And more instrumentation patients had before the procedure, such as ERCP, the higher chance of the islet contamination. That does not necessarily lead to infections. However, we do keep them longer on antibiotics. So anemia primarily is actually dilutional anemia, just because it's a large procedure. It's open procedure mostly. They remain open on the table for a long time, and infections are quite common as well. And as I mentioned, chyle leaks is common in this patient population. At least historically, we had about 70% readmission rate within the first year. The GI issues is probably the main problem, because the tube fits problem, they get constipated, they get gastric distension, and then that's goes back and they say that they have pain, and it's kind of a very evil circle. So really addressing the GI issues is a big thing in order to prevent those readmissions. So in terms of long-term outcomes, we're looking at quality of life as well as pain relief and glycemic control. So from health quality of life standpoint, from one of the SF36 surveys, it's been shown that at 2 years, both physical component and mental component of those patients improved from pre-transplant, and especially it was true among patients who actually were insulin independent. More recent survey of almost 500 patients indicated that both mental and physical component improved among adults and kids, and actually kids did better, and they had more improvement than adult patients. So when it came to pain relief, up to 85% of patients report improved pain at 2 years following transplantation, and at 2 years, 59% of them off narcotics. More long-term study actually showed that, again, even up to 10 years, the pain has improved, but even at that time, at 10 years, some of them still report that they have a pain associated with pancreatitis. So it's a central sensitization, which is a problem, and this is one of the areas of research that needs to be addressed. Unfortunately, a number of those patients remain on narcotics, but this is all-cause narcotics rather than pancreatitis. Lastly, the glycemic control. So this was evaluation of almost 500 patients, and insulin independence was better again among children, and there's definitely prolonged islet function. This is up to 5 years. This data will be published very soon. And if you break down further between teenagers and kids, younger kids do better with the glycemic control over time. In terms of preoperative predictors of insulin independence, it's been shown that younger age, lower BMI, and metabolic functions such as the fasting glucose, hemoglobin A1C, and C-peptide can be predictive of improved insulin independence. However, multivariate modeling can only predict about 70% of those patients, so there are definitely some patient-specific factors that are not being addressed. So despite big surgery and despite significant complications, the patients have the survival, long-term survival historically was up to 72% at 10 years. Again, the major cause of death was infections, and this is again, and could be sepsis, and it also other types of lung infections. So this is, again, something to improve upon in those patients. However, the only factor, preoperative factor that was identified associated with outcome is the high preoperative BMI. So in conclusion, TPIT became the acceptable option for adults and children with chronic and acute recurrent pancreatitis. In well-selected patients, procedure offers improved quality of life, pain relief, and acceptable glycemic control. Current research focus is on improving longevity of islet allografts. And there are other things that we definitely need to address, such as postoperative GI dysmotility, as well as central sensitization for those patients. So I would like to thank you for your attention. I apologize that I had to sit down during my talk. And I would also like to acknowledge 2 of my teams, both from University of Minnesota and from Stanford. Thank you.
Thank you very much for this comprehensive overview, Dr. Krishner. It's a very hot topic. Are there any questions? Yes, please. Please state your name and institution.
Thank you. Mark Besseling from Amsterdam. Thank you, those are outstanding. Can I ask you a question about the indication for total pancreatectomy? So we had the recent guidelines in Annals of Surgery on TPIAT indication regarding chronic pancreatitis. Basically stating that in a patient with a dilated duct in chronic pancreatitis, because if you do drainage surgery first, outcome would be worse for TPIT, and thus advising to do an upfront TPIT, which to us from Europe is very strange because of the excellent outcomes in this specific group of chronic pancreatitis with a wide duct. What is your view on this?
So you're absolutely right. So in our program, if it's patient, it depends on the patient. So if they have, as I said, duct over 7 millimeters or 7 millimeters, and you can actually perform drainage procedures, we try to do that first and then move to the total pancreatectomy. However, if it seems like they have a genetic predisposition and the disease is not going to be corrected by the drainage procedure, we definitely recommend the total pancreatectomy and
Sure.
autoiler transplantation.
That's a tiny subgroup, right?
Huh?
That's a tiny subgroup of those.
Yeah, it's, well, as I showed earlier, that there is actually over 50% of our patients right now are diagnosed with the mutations that are associated with chronic with pancreatitis. So it's it's hard to say whether or not its indications changed or we're just so good at genetic testing, and. I do believe so, and also we consider the age of the patients. Again, if it's an older individual, and this is extremely big procedure, we recommend against doing the total pancreatectomy. However, if it's a younger individual, then we sway them towards more doing the
So that's interesting because we only do the genetics for cancer, which is then 2%, and the rest we do drainage surgery in Europe with a 85% 10-year good result of pain score less than 4. So that's the remaining debate, I think, for the indication chronic pancreatitis.
Yeah.
Thanks.
Thank you for your question.
Yes, please. Please state your name and institution.
Hi, I'm Aman Kumar from UNC. So my question is that what is the ratio, like how many patients that come with pancreatitis referred to you, how many undergo the TPIAT procedure, and how many undergo Whipple or distal or a drainage procedure? So what's the ratio?
That's a very good question, and I cannot tell you that because I was specializing primarily in total pancreatectomies. My partner was actually doing everything.
Yeah.
So, and I'll be honest with you, I do not know the ratio in terms of how many undergo total pancreatectomy. I can tell you that our average of doing cases, University of Minnesota's average of doing cases, it decreased probably from about 50 a year to now about 40 a year or so, but that also includes kids. So, and in kids, a lot of it is a genetic mutations, so.
And what is the number of rest of the pancreatic cases, the operative cases that are done? Like at our center, what we do, what I have seen is it's almost close to like the ratio is 1:1. So almost 50% of the patients, they undergo a procedure. Eventually they might come for a TPIT later on if the disease progression, kind of gets them there. But the ratio has been kind of around 1:1.
Yeah, I cannot tell you the ratio, but more likely if it's an older individual who is still smoking, who has multiple other comorbidities, we'd rather do the drainage procedure than doing the total pancreatectomy. Let's put it this way.
Thank you.
Any more questions? I have, if I may have one comment and one question. We in Europe are relatively concerned about the incidence of unsuspected carcinoma in chronic pancreatitis. That's the reason why we usually do a frozen section during surgery. And it's a catastrophe that you isolate islet cells from the whole organ, and you perfuse or you infuse then pancreatic carcinoma cells. And the incidence is not low, it's 10% in our extensive clinic, which is dealing very much with chronic pancreatitis, 10% of patients who are referred to us with a diagnosis of chronic pancreatitis turn out intraoperatively to have a pancreatic carcinoma. What is your attitude to this?
So you're absolutely right, and this is a devastating thing, as I demonstrated in one of the cases that was published. Again, if it's patient who has risk factors, again, chronic pancreatitis, older individual, smoker, we do send for the pancreatic, and if there is any other concerns, we do send for the pancreatic tumor markers. I know they're not perfect, and this particular individual actually did not have elevation of a standard pancreatic tumor markers. Eventually, he was diagnosed with certain pancreatic mutations that would predispose him to pancreatic cancer, but that was all retrospectively with additional genetic testing. So, but we also, a lot of patients that we see, I operate on a lot of 20-year-olds. It's, again, it's a different disease and it's a different etiology. I did not put any photos of my patients in this talk, but a lot of them 18, 20-year-olds who could not go to school because of this recurrent acute pancreatitis, is not necessarily even chronic pancreatitis.
You had a question.
Do you differ in a type of technique in doing a total pancreatectomy for a tumors or something else, like versus total pancreatectomy planning for auto islet cell transplant? Like, in the sense, vessels, do you ligate early, like artery, splenic artery, or do you take any special precaution to decrease ischemia time?
No, thank you. This is actually a very relevant question, and I should have mentioned it in my talk rather than leaving it to someone to answer. Yes, we're trying to preserve the blood supply until the end for pancreatectomies when we plan to perform islet isolation. In general, I do most of my procedures laparoscopic hand assist, and then I'll do the last reconstruction portion through the small incision of the hand port. In terms of the arteries, the splenic artery supply remains until the end. Very often they're again, it depends on the patient, but if they're extremely inflamed and it's very hard to identify anatomy in the head of the pancreas, I do take a GDA early because it just minimizes the bleeding, to be honest, so, and helps with dissection.
So I think I'm sure that there are many more questions, but I think we have come to the end of the session. The next session is waiting. I thank you very much for your presentation. It was excellent overview. Thank you very much.
Thank you for your attention.